Hello, everyone. My name is Daniel DeLuca, and I'm an assistant professor of neurology at Washington University in St. Louis. And today I'm going to talk about the role of neurofilament light chain in multiple system atrophy, as suggested by the conference's committee. I have no relevant disclosures to this presentation. I'm going to structure my presentation in a few topics, including what is neurofilament light chain and some of its use in diagnosis, tracking clinical progression, radiological progression, prodromal disease, and how we can use neurofilament light chain in clinical practice, research, and also for our patients. Just a brief overview, although I think the audience here knows quite a lot about multiple system atrophy. We all know it's a neurodegenerative disorder with a broad range of symptoms. It is still considered a relatively rare disorder with a frequency around 3 to 5 per 100,000 population in the United States. The symptoms can vary significantly, and there is a broad range of complications, including neurological, psychiatric, autonomic, cardiological, and also involving the GI system, as we all know. Now, when we're talking about clinical biomarkers, we have to keep in mind that there are many goals and many different types of biomarkers. If we think about neurofilament light chain, we can also kind of use this as a guideline to better understand this presentation. A biomarker can be diagnostic. So if we think about MSA, a biomarker can help us differentiate MSA from other conditions like Parkinson's disease or healthy controls that don't have MSA. And this is obviously very important when you're trying to include patients in clinical trials. We have to make sure that we have an accurate diagnosis of MSA, for example. A biomarker can also be predictive, meaning you can look at patients prior to the development of symptoms, and you can try to identify which of those patients are going to develop MSA in the future. So we're actually looking before they have any symptoms and trying to understand which one or which patients are actually going to develop the symptoms later on, perhaps years later. A different type of biomarkers are those that can track clinical progression, meaning depending on the level of biomarkers, we can identify which patients are going to progress faster or perhaps develop symptoms like requiring a wheelchair, or perhaps patients that might die faster compared to those who do not have a similar characteristic in terms of biomarker. And this is also obviously very important for clinical trials, as it can allow us to better match participants and make sure that they have similar disease characteristic when we're comparing those in clinical trials. But it's also extremely important when talking to patients. If we do have biomarkers that can allow us to better understand the clinical progression, we can provide better information for patients and families. And finally, biomarkers can allow us to better understand the response to treatment. As an example, if we have a group of patients that has been receiving a certain treatment, we can evaluate this biomarker to check who is responding or not responding to treatment, depending on the changes in these biomarkers. For instance, a biomarker can decrease in levels if the treatment is working, if that has been previously proven, and then we know that we can continue treatment. Perhaps this biomarker remains the same or goes up, and then we know that they're not responding, so we should perhaps change treatment or our interpretation about this efficacy. And as I mentioned before, these different biomarkers or roles of biomarkers can really allow us to design better clinical trials, better research, but also can allow us to have a better understanding of the disease, to really dictate our treatments and have a better discussion with family members and patients. Now, We can discuss neurofilament light chain, what it is, and its role. We know that neurofilament light chain is a subunit of a protein of neurofilaments that are part of the axons. These neurofilament light chains are one of the subunits that provide stability to the axon of the neuron, meaning it is one of the parts of brain cells. And healthy brain cells, they all have neurofilament light chain that provide this stability to the axons of the neurons, which is this part here we can see in the picture. Now, all of us have neurofilament light chains, and all of us do release slow amounts of neurofilament light chain over time. And this goes first to the spinal fluid, which is the fluid surrounding the brain. And later on, it goes in lower concentrations to the blood or plasma. And over time, we have developed analytical platforms that allowed us to quantify this neurofilament light chains in the blood, but also in the spinal fluid of patients. As I mentioned before, we all release neurofilament light chain over time. And this is progressively higher the older we are. So as you can see here, depending on the age group, you can release a higher or lower amount of neurofilament. And this has obvious implications to the interpretation of the level of neurofilament over time, and obviously in patients with MSA as well. Now, what is interesting about neurofilament light chain is that a lot of groups have shown that there is a higher level of neurofilament light chain in the spinal fluid, and very likely in the blood when there is neuroaxonal pathology. So when there is any alteration in the structure of the axons or the brain cells, any kind of stress or inflammatory response or any injury, you can disrupt the normal regulation of axons, the normal structure of brain cells, and this can, in consequence, increase the levels of neurofilament in the spinal fluid and also in the blood. And this has obvious implications to this biomarker that can perhaps allow us to better identify these conditions that cause this disruption in the normal structure of the brain and axons. Here is a graph showing how many disorders can impact the levels of neurofilament light chain in the spinal fluid. And what is important to notice is that depending on the condition, you can have higher levels of neurofilament. And this is usually the case in disorders that can be more aggressive or faster in progression that result in a more significant axonal pathology or a more significant disruption of this normal brain structure or brain behavior and resulting in higher levels of neurofilament light chain in the spinal fluid. So as you can see here, conditions like ALS or amyotrophic lateral sclerosis or multiple sclerosis do have higher levels of neurofilament light chain. And if we think about Parkinsonism or movement disorders, we can see how those atypical Parkinsonian syndromes like multiple system atrophy, progressive supranuclear palsy, do have a higher levels of neurofilament light chain as compared to Parkinson's disease. And that's because they progress faster and they're more aggressive, as we know in clinical practice. Over time, we have developed highly sensitive platforms that have allowed us to reliably quantify neurofilament light chain in several body fluids, including spinal fluid surrounding the brain, in the spine, as well as in the blood. Recently, we have developed several clinical studies looking at cohorts of patients to validate the use of neurofilament light chain in research and clinical practice. However, we're still pending full regulatory approval for the use of neurofilament light chain as a clinical biomarker in several neurological disorders, including MSA. Now, we can talk about the diagnostic use of neurofilament light chain in multiple system atrophy. One of the first studies looking at the diagnostic accuracy of neurofilament light chain in MSA was this one done by Holmberg in journals in Sweden in the 90s, looking at the diagnostic accuracy of neurofilament light chain and Parkinsonism. So they looked at about 40 patients comparing Parkinson's disease with PSP and MSA. And as expected, the conditions that are more aggressive or faster, like multiple system atrophy and progressive supranuclear palsy, do have a higher level of neurofilament light chain. Therefore, it was suggested that it could potentially allow us to diagnose these conditions when in doubt about the underlying pathology. This has been subsequently evaluated by several groups, including the Dutch group that confirmed some of these findings of spinal fluid, neurofilament light chain, being able to differentiate MSA from other conditions that progress slightly slower, like Parkinson's disease. Over time, several other groups have replicated these findings. And what is interesting is that some groups have also suggested the possibility of combining neurofilament light chain with other biomarkers. So this is a work done by the Toronto Western group, including Dr. Martinez-Valbuena, Dr. Kovacs, and Dr. Lang. And they analyzed the potential of using neurofilament light chain along with other biomarkers that have been suggested to being very sensitive and specific to multiple system atrophy. For instance, the main one now is the RT-QuIC, or the seeding assays for alpha-synuclein. And we know that these assays can allow us to differentiate between alpha-synucleinopathies, so those conditions that accumulate alpha-synuclein, like Parkinson's disease, multiple system atrophy, and dementia with Lewy bodies, compared to those that do not accumulate alpha-synuclein, like progressive supranuclear palsy and cortical basal degeneration, among others. So the idea was that we could potentially use these seeding assays to identify the accumulation of alpha-synuclein, but that by itself doesn't allow us to differentiate between PD, MSA, or DLB. So by combining neurofilament light chain, we could overlap these results and identify the patients that have not only alpha-synuclein, but also increased levels of neurofilament light chain. And they have suggested that, as we can see here, it can be quite a specific result to identify these patients with MSA. So if we look just at the accumulation of alpha-synuclein, we can see that patients with PD and MSA obviously have higher levels of alpha-synuclein. Therefore, it can allow us to differentiate those that accumulate alpha-synuclein. But on the other hand, patients with MSA have higher levels of neurofilament light chain, as we discussed before. So we could combine these two results and demonstrate that we could appropriately identify patients with MSA among those with unspecified Parkinsonism. Now we can look at the role of neurofilament light chain in tracking disease progression. As of now, we use the unified MSA rating scale as the gold standard for clinical progression in multiple system atrophy. However, we do know that there are several limitations to the use of the MSA rating scale, including responsiveness to progression. So we know that they do not necessarily correlate with how severe a patient is. There is a ceiling effect to the rating scale, meaning at a certain level, if someone gets sicker and more severe, there is a maximum score there that they cannot go up. So it doesn't truly reflect someone who has a very severe disease progression compared to those who might have just a severe progression. And there are also issues with content, construct validity, as well as reliability. And that's not to criticize the MSA rating scale. It is still one of the best, if not the best, way of identifying clinical progression. However, as a field, we do acknowledge that we need more objective biomarkers to identify clinical progression in multiple system atrophy. A few years ago, this large study was published in Brain. This is a study by Shelban and Holden, which was a large multi-center study evaluating neurofilament light chain in the blood and in the CSF of a large number of patients with multiple system atrophy. These patients were followed for 2 years, so we could have longitudinal data of these patients over time. It's worth mentioning that not all patients did have CSF collection or spinal fluid collection, which was only done in a selected group of patients. One of the most important findings of the study was the suggestion that, one, we could correlate the levels of neurofilament in the spinal fluid and the blood, meaning there was a high level of correlation between these two measurements, which is obviously easier to obtain neurofilament in the blood as compared to spinal fluid. If that's correct, it would allow us to get a much less invasive measurement of neurofilament light chain. We know that to get spinal fluid, we require a neurologist usually, or a physician to perform a lumbar puncture, where for blood measurements, we can simply go to the lab and collect those. So if there is a high level of correlation between those two in MSA patients, that would be quite an exciting finding. And as we can see in the picture, one of the other major findings of the study was the correlation between neurofilament light chain in the plasma and the progression of the disease as measured by the MSA rating scale, meaning patients that are more severe, that have a higher MSA rating scale score, also have a higher neurofilament light chain level in the blood and in the CSF, potentially allowing us to track disease progression by simply measuring the neurofilament light chain. Additionally, the authors also mention and highlight the possibility that high levels of neurofilament light chain in the plasma can correlate a higher mortality as compared to those patients who had a low level of neurofilament light chain in the plasma. Finally, the authors also describe that there is a high level of correlation between neurofilament light chain in the blood and changes in brain volume as measured by MRI brain. Specifically, they noticed that there was a lower brain volume in the parts that are affected by MSA, including pons, striatum, cerebellum, and middle cerebellar peduncle in the patients who had a higher level of neurofilament light chain, suggesting that perhaps it does correlate with disease progression and more severe forms of MSA over time. So as a conclusion, the authors of this study suggested that NFL can be an accurate biomarker or reliable biomarker by measuring severity, future clinical progression, survival, and brain changes over time in patients with MSA. And their final conclusion is that we could potentially use NFL in future observational and therapeutic studies for MSA, including clinical trials. However, just last year, another very important study was published in the Clinical Autonomic Research Journal, looking at patients with MSA, Parkinson's disease, and healthy controls. This study was done by the Mayo Clinic group, and although it enrolled a lower number of patients, just 32 as compared to 200 in the other study, all these patients did have CSF and a more detailed clinical evaluation. And as we can see here, they did confirm the finding that neurofilament light chain in the spinal fluid could differentiate patients with multiple system atrophy from Parkinson's disease and healthy controls. And they also show that to a lesser extent, we could potentially use blood as a biomarker to diagnose those patients, although it looks like CSF is still the most reliable biomarker. However, which was a surprise compared to the previous study, they could not replicate the finding that neurofilament light chain in the spinal fluid or in the plasma did correlate with clinical progression. As we can see here, longitudinally, over 3 years, the levels of neurofilament light chain in the spinal fluid really don't change much, despite those patients having a more severe form of MSA over time, and the same with neurofilament light chain in the blood. So as a conclusion in this study, the authors confirmed that neurofilament light chain in the spinal fluid, but perhaps in the blood, could differentiate MSA from PD in healthy controls. But they did not really observe this high level of correlation between the two measurements, blood and the spinal fluid, as the previous European study. And finally, they couldn't confirm the finding that plasma and CSF neurofilament correlated with disease progression. In this editorial, both myself and Dr. Milar Vernetti from NYU discussed some of the challenges in both studies, and we suggested that we do need additional studies to confirm the possibility that CSF and blood neurofilament light chains correlate, and that there is any correlation with clinical progression. We have two very good groups with two very good studies with results that are not in agreement. Plus, we also discussed some of the challenges of using neurofilament, which I'm going to discuss in more details later on, but the contribution of other neurological disorders and the contribution of peripheral neuropathy and other forms of axonal injury to higher levels of neurofilament light chain, and how that can contribute to some of the changes seen in those studies. As I discussed, it can also be extremely helpful to have a biomarker that allows us to understand who is going to develop MSA even before they have the first symptoms. And probably many people here know the concept of prodromal disease, but what I mean by that is looking at patients before they have the first motor symptoms of MSA. And we know that one of the strongest risk factors for developing MSA, or one of the strongest symptoms before the motor onset of MSA, is REM sleep behavior disorder. So if we follow up patients with dreaming nighttime behavior and REM sleep behavior disorder over time, a subset of those patients will develop a form of alpha-synucleinopathy, including Parkinson's disease, MSA, and dementia with Lewy bodies. However, we still don't know which of those patients are going to progress to develop those neurodegenerative diseases. So this group from China suggested that neurofilament light chain could be one of the biomarkers that would allow us to understand which of those patients can phenoconvert to an alpha-synucleinopathy, meaning we can collect neurofilament light chain, and depending on the level, if too high, we can understand and predict that they're going to develop one of those three conditions in the future. This study does not yet allow us to differentiate who is going to develop Parkinson's disease, MSA, or dementia with Lewy bodies, although some other groups have suggested that perhaps an even higher level of neurofilament light chain could predict the development of MSA even before they have the symptoms. And this has huge implications to the field. This is much more discussed in the field of Parkinson's disease, where several clinical trials have been designed trying to prevent Parkinson's disease in patients who might have prodromal symptoms, meaning you can identify those patients and start a treatment early on to the point that you prevent the development of the motor symptoms. And I would expect that a similar movement would also be present in the field of multiple system atrophy. So having a biomarker that can reliably predict who is going to develop these diseases would be extremely important. And that's why this study is definitely worth mentioning. As I discussed, one of the main challenges is what's the best fluid to detect neurofilament light chain. Blood is obviously easier to get, but as of now, we cannot say with confidence that serum neurofilament light chain correlates with spinal fluid or the fluid that surrounds the brain in patients with multiple system atrophy. The concentrations of neurofilament light chain is way higher in the spinal fluid, which obviously depends on the integrity of this blood-brain barrier, which means this kind of barrier that protects the brain and the spinal fluid from the blood. So there is a normal barrier there, and depending on how damaged or how healthy this barrier is, it would change the concentrations of neurofilament light chain in the blood. However, I think we all have a consensus that the spinal fluid neurofilament light chain is a more reliable diagnostic marker. Now, in clinical practice, neurofilament light chain can be quite useful to differentiate MSA from Parkinson's disease. Although it looks like the answer is not going to be neurofilament light chain by itself. Most likely, we're going to use neurofilament light chain in combination with other biomarkers like the sitting assays, or perhaps imaging biomarkers that have also been very exciting in the past few years. And finally, we can discuss the role of biomarkers in respect to responsiveness to treatment or clinical trials. As of now, it is difficult to suggest that neurofilament light chain might change in respect to treatments, especially because we don't have any treatment that is effective for MSA. However, we can expect that potentially, if there is an effective treatment, the levels of neurofilament light chain will decrease. In the study by Shelban, published in Brain, they did estimate how a clinical trial would be designed if we use neurofilament light chain as a biomarker. And if we expected a 30% reduction in the annual neurofilament light chain levels, we could potentially enroll 14 patients in each group, with a total of 28 participants in this clinical trial, which would be a very reasonable number of patients. And perhaps it's an exciting result showing that it could be a feasible possibility if, again, we can replicate the findings that neurofilament light chain track clinical progression accurately. Now, there are several limitations to the use of neurofilament light chain. One of them is aging. As I mentioned before, older patients do have higher levels of neurofilament light chain, so we do have to adjust for that when we are interpreting the results. However, there are several other conditions that can impact the levels of this biomarker, including chronic kidney disease and BMI. Now, after neurofilament light chain is released, there are also several processes in our body that can change the levels of this subunit, including degradation, clearance, and post-translational modifications, and which would require harmonization of different analytical platforms. So having some sort of homogeneous methodological process to allow us to talk to each other no matter what kind of methodology we use. As I discussed, there is also the possibility that patients might have more than one condition that increases the level of neurofilament light chain. And we still don't know exactly how to differentiate those. For example, patients with peripheral neuropathy can have higher levels of neurofilament light chain. So how do we interpret results when patients have more than one neurological condition remains unclear. Finally, most of these studies have been done in a predominantly white North American or European population. So we don't truly know how the levels of neurofilament light chain can change according to race and ethnicity. I'm not going to discuss too much about other biomarkers, as other presentings are discussing those in this conference. However, there have been several promising biomarkers in MSA, including sitting assays, looking at alpha-synuclein, as well as a skin biopsy, and imaging biomarkers that have advanced over the past few years. Now, where do we go from here? We certainly have to expand our methods And again, have a homogeneous understanding of methodology so we can talk to each other no matter where we're performing these tests. We need to include a diverse cohort in terms of race and ethnicity and to make sure that this is not different according to the population. We need to better understand the correlation between CSF and plasma neurofilament light chain and make sure that there is a high level of correlation between those that would allow us to perform a less invasive measurement of neurofilament light chain. We also have to understand the role of neurofilament light chain in combination with other biomarkers, and if we can potentially use these results in combination with other biomarkers that have been advancing in the field of movement disorders. And finally, we have to confirm how neurofilament light chain behaves in response to treatments for MSA, and if they can truly be used as a biomarker in clinical trials. So as a conclusion, neurofilament light chain is a promising biomarker in the field of MSA, which can have a broad range of uses, including in diagnosis, in predicting who is going to develop MSA, in tracking clinical progression, and also allowing us to monitor response to treatment potentially. This is going to be an important biomarker that might be used in clinical trials and in the development of new drugs for multiple system atrophy, but it can also allow us to potentially give a more accurate diagnosis and give a better understanding and prognosis to patients and families. We do have to standardize our current analytic platforms, but we certainly need more research to be done to answer some of these questions about the reliability of neurofilament light chain as a biomarker in multiple system atrophy. With that, I will conclude my presentation, and I will be happy to take any questions. Please feel free to reach out if you have any suggestions, questions, or concerns, and happy to continue this discussion outside of this conference. Thank you very much for your attention.